And good afternoon. If anyone, I would like to just do a double check and see if everyone can hear me. If anyone would like to unmute and let me know if you can hear me.
We can hear you.
Wonderful, wonderful. And I see everybody's gotten our, great, great. I'm going to give just a moment for everybody to log on. It's not quite yet noon, but delighted that folks are joining us on such short notice to get started. I just finished hospital rounds with my team of residents myself, so I appreciate everybody in masks and face shields. I think I found the most comfortable face shield around. Very stylish, don't you think? Amazon for $2. All right. And this is being recorded. When you signed on, did anyone receive a message about this being recorded? I'm just curious.
No.
No.
I think perhaps when you registered, were you given that knowledge?
No.
These are recorded, and I think it is important for everybody to know that it is required by Project ECHO. And I'm just going to, I think we're just about there. I think we have a few more folks to join us. And I'm just getting the list of participants to make sure everybody gets credit for being here. Oops. Okay. All right. Well, good afternoon. It is 12:01, so I will go ahead and get started. I am Michelle Bellantoni, and I am the Clinical Director of Geriatric Medicine at Johns Hopkins, and I'm Vice President of the Mid-Atlantic Medical Directors Association. My academic work here at Johns Hopkins in geriatric medicine is in the post-acute care transitions. I just finished morning rounds. I actually was naming a couple of your facilities on morning rounds with my residents as we're about to send a few patients there. I hope those discharge summaries are up to par and the communications are great. None of these are COVID patients, thank goodness, but certainly medically complex patients. So I certainly work in the hospital setting, teaching our young residents and medical students, but have been a medical director since 1997 in post-acute care, and certainly appreciate all the time and effort you're all putting into COVID. And we are, I'm sure, just like you, gearing up for COVID this week. We here at Johns Hopkins Bayview have opened a new floor yesterday and another one today. Johns Hopkins Hospital, the same. We're at capacity right now and very challenged to do throughput because COVID is increasing. So let me tell you a little bit about Project ECHO. It is a nationally funded project from AHRQ, which is a national federally funded agency for quality improvement. The Project ECHO team has been working for many years in educational projects where they pair academic centers and community medical providers and to improve quality of care. It started out with hepatitis management. Now, over the summer, they began, and our Hopkins hub here was very busy with COVID management in acute care hospitals and biocontainment units. So that was the first Project ECHO hub at Hopkins related to COVID. This is a specific hub for nursing homes and pairing our community nursing homes with hospitals. So I'm delighted to be working with all of you. Let me tell you a little bit about the project. We will be meeting for 16 weeks. Our sessions are supposed to be an hour to an hour and a half. They will be Thursdays. They will be Thursdays starting at 11 o'clock, not this week or next week, and not the week of Thanksgiving, but the following week. We'll move to 11 a.m. to 12:30. But for this week and next week, I must be on ward rounds with my residents until noon. So that's the reason for the change in time, and I appreciate your flexibility this week and next week. Okay. Each session will have topics, and I'll review those with you in a few minutes. We'll start off with a video that explains the project, but before I do so, does anybody have any questions before we start? And I see somebody's put a chat in. Let me see. I see Dee Anderson there in Abington Manor. I would actually ask if everybody is familiar with this technology in the chat, if you would put your name and facility, because that is actually part of our recording and will be very helpful to make sure we have not missed anybody in our registration, so that you are receiving credit and your facility is receiving credit for participation. So if you'd all just take a moment and put your name and facility in the chat box, that'll just be sure that we have you in the registration, and very important to us that we make sure everybody is given credit. We have applied for continuing education credits for administrators and nurses. Because of the short notice, this session will not be given credits, but going forward, we do hope we'll have that completed in time so that nurses get CEU credits and administrators get nursing home administrator credits. We also have the ability, if there are any physicians who join, medical directors or physicians, to give AMA credits for physicians as well. So I think that's very important. Okay, let me stop there. Any questions? Hearing none, I'm going to share my screen. So let me get started there. And that is my somewhat hectic calendar, which you don't need to see, but let me get to the AHRQ site, and we're going to start with a video that the AHRQ has as an introduction to this project.
Hello and welcome to this fast-paced presentation on COVID-19, Stopping the Spread. We are going to highlight actions to take and highlighting some key strategies for screening and testing today. We know that an essential component of the prevention of spread is to prevent the virus from entering your facility. Good screening in combination with testing are essential components for success. My name is Lisa Thompson, and I'm the Chief Strategy Officer for Pathway Health. And also joining me today is Sue LaGrange. She's the Director of Education, and she leads the COVID Task Force for Pathway Health Service and is also a board-certified infection preventionist.
In order to put in place a good system, putting together a team of professionals will help you to review all expected state and federal guidance, then to develop policies and procedures, identify necessary supplies that are going to be needed, and then contact vendors to access those supplies, provide initial and ongoing education to the employees, and then monitor for compliance. Education will need to be done initially and ongoing, and needs to include the entire process, from equipment use, when to test, how to collect specimens, PPE, personal protective equipment necessary, hand hygiene, how to read results, reporting, cleaning and disinfection, and what they're supposed to do with a positive result. So it's going to be important to assign authority for the whole process.
Another aspect in stopping the spread in our organizations is the part of preventing the spread is to prevent the virus from entering the building at all, and that's screening. So that means screening of employees, visitors, vendors, contract staff, and those alike. It's very crucial to success. Screening must be active screening, meaning staff cannot self-screen. Also, when we look at this and when we're doing the screening process, we know we look at signs and symptoms, but one thing is key to remember is that fever is defined as 100 degrees or higher for staff or for residents. and a temperature of 100 degrees Fahrenheit or more than 2 temperatures above 99 degrees Fahrenheit is also considered a fever. So again, making sure that we have up-to-date screening tools and we're actively screening our residents, our staff, and visitors or vendors, and making sure that we're following the key components and we're not self-screening.
There are several different types of testing. There's diagnostic testings for SARS-CoV-2, which is coronavirus or COVID-19, and that's intended to identify current infection in individuals and is performed when a resident or person or staff member has signs or symptoms that's consistent with COVID-19, or if someone is asymptomatic but had recent exposure or suspected exposure to COVID-19. Next is screening testing, and this for COVID is intended to identify infected persons who are asymptomatic without known or suspected exposure to COVID-19 or SARS-CoV-2. Screening testing is performed in order to identify persons who may be contagious so that measures can be taken to prevent further transmission. The CDC also talks about surveillance testing, which is strictly used for public health surveillance, so we won't be talking about that today.
And we also know part of the testing protocol is looking at the rapid antigen testing. And we know it can be used at point of care. And we also know how quickly we can get the results within about 15 minutes. And it can be used for screening in high-risk settings, such as in our communal settings in long-term care, and all allows for prompt implementation of our infection prevention and control measures in order to prevent spread within our organizations. So we know facilities, we've received our rapid antigen devices for point of care rapid antigen testing. And generally we know that they're less sensitive than the viral testing that really detects the nucleic acid using. So that's part of that, the RT-PCR testing. And we also know it performs best when individuals tested in the early stages of COVID-19 infection. So that means the viral load is generally at its highest.
For employee testing or staff testing, it is completed for staff that have signs or symptoms of COVID-19 based upon screening or if an employee indicates that they now have symptoms. Asymptomatic staff also with known or suspected exposure, whether it is inside or outside the facility. Also, staff testing is completed for asymptomatic staff according to routine testing by the community COVID-19 positivity rate. Staff testing is also completed for staff who have been diagnosed with COVID-19 to determine if no longer infectious, only in some cases, because the CDC does indicate that a test-based strategy is no longer recommended, such as someone who is severely immunocompromised, because in the majority of cases, it results in excluding from work the healthcare personnel who continue to shed detectable SARS-CoV-2 RNA, but they are no longer infectious.
And we know there are 3 triggers for testing. When there's a asymptomatic individual identified, and any new cases in the facility, even one case is considered an outbreak for COVID-19, and routine testing in accordance with CMS guidance. So again, you can see the testing, the triggers that they're on the far left-hand side. So for outbreak testing, all staff and residents should be tested, and all staff and residents that tested negative should be retested every 3 to 7 days until the testing identifies no new cases of COVID-19 infection among staff or residents for a period of at least 14 days since the most recent positive result. For more information, please review, the section that is entitled in the document that you can see here, and the link that there's a section in the QSO memo that goes into more specific details.
It is also documented that when there are significant cases of COVID-19 in the county or in the community, the chances of COVID-19 coming into your building, sometimes by asymptomatic staff who unknowingly bring it in, is higher. This is why routine testing is determined by the community COVID-19 activity level. And as you can see, there is a graph on the slide that indicates the minimum testing frequency based on the county positivity rate in the past week.
And you can see here on the slide here, there's the link to a great website for all of us to go back to and refer to, because CDC indicates that all testing for SARS-CoV-2, including the rapid antigen testing, is directly impacted by the integrity of the specimen, which really depends on specimen collection and handling. So this website is available to us, and it's very essential that whoever is collecting the specimens for testing is donning the most appropriate PPE, and that needs to include first, perform hand hygiene, then don your gloves, gown, N95 respirator, and face shield or goggles.
Next is follow-up with the test results. Immediate placement decision for a resident. For example, placing a resident on a COVID-19 positive unit on precautions if symptoms and a confirmed positive test. We will discuss that more on the next slide. For employees, we would send them home immediately and work with employee health for follow-up. And then notifications, physician, resident representative, and other reporting, public health, CLIA, NHSN, all residents and representatives per facility leadership. Retesting in accordance with the tables discussed earlier. And also the facility plan for new cases, room moves, and emergency staffing. I do want to indicate that follow up with test results, when we're looking at that immediate placement decision for a resident, it is important that before we put them on a COVID-19 unit, that we do have a verification of that confirmed test result.
And another strategy for stopping the spread in your organization is resident placement, as Sue talked about, and making sure we have that good, solid testing strategy in place. That resident placement is having that need of a dedicated space or location for your COVID-19 care unit and a staffing plan for dedicated staff or consistent assignment with their own restroom, break room, and other work area that is separate from those caring for the other residents in your organization. Dedicated equipment is essential for this unit as well. It should be cleaned and disinfected if using in between residents on the COVID-19 care unit. And for any exposed residents, new residents, or suspected residents, until testing is completed, residents should be quarantined. Private room with their own bathroom, ideally on a quarantine unit or a space with no cohorting.
Additional measures, as Lisa indicated, consistent assignment and dedicated staff is essential, but it's also important that if you have housekeeping, that they are also dedicated to that unit with the same break room and employee restroom as well. PPE use in accordance with the best practice approach with CDC and your facility policy and procedure, and following CDC's optimization guidance. Next, hand hygiene, hand hygiene, hand hygiene. It's important that staff are following good hand hygiene. And then cleaning and disinfection in accordance with best practices using EPA registered list N against SARS-CoV-2, which is COVID-19. And of course, making sure facility staff are following all of your policies and procedures with COVID-19.
So in summary, with our short little presentation here on stopping the spread, early identification of an employee or resident is crucial in the prevention of the spread of COVID-19 in long-term care facilities. Active screening for all and testing in accordance with the most recent guidance will provide information to put prompt mitigation steps in place in order to stop the spread. Sue and I want to thank you today for participating in this presentation on some key strategies on stopping the spread within your organization.
And so that was meant to be kind of a general overview. And I'm just looking at the chat to see as people were logging on, and they would like changing the time of noon. We are changing the time of noon. The reason it was noon today was because I'm hospital attending and have to make morning rounds from 8 to noon with the internal medicine residents here at Johns Hopkins. And that's this week and next week. And then after that, we'll break for the Thanksgiving week, and we will then reconvene at 11 to 12:30 after that. So I will be changing the time and the registration after the next 2 weeks. So thank you for bearing with me, because I do appreciate that the CNAs are feeding residents at this time and can't be participating at this time. Your Genesis leadership insisted we get started this week, and I understand that because other facilities, other groups have had started, and because COVID is really increasing across our region. So thanks for bearing with me. Let me just ask a technical issue. Could you hear that video well enough through the sharing? I'm seeing nodding yes. Okay. And are there, I think that was a quick overview of all the topics of COVID management, and over the 16 weeks, these topics get broken out in much more detail and more discussion. But to begin with, is there anything on that video that surprised you or worried you? And feel free, please, to unmute. And are you able to unmute yourselves at the bottom where you have the microphone in the bottom left? Could somebody unmute and just tell me you can do it?
Yes.
Excellent.
Yeah.
Anything you saw there that you said, wait a minute, we've been doing COVID now since March, and that's not what we're doing, or that's pie in the sky and we can't do that? Because I had a few reactions to that video myself.
I didn't see anything new there that we weren't doing.
That's what I thought too. But at least in some ways, to me, it reinforced what we're doing. What are the biggest challenges right now? I can tell you what my challenge was when I was leaving last night. Was I had 2 young doctors with children whose daycares had COVID exposures. And so I had to quickly find others to do their duties today. You having that problem with your staff?
Staffing is definitely the biggest issue, especially when you're supposed to keep same staff on the unit.
Yep, I agree very much.
It's also a problem because if someone has a symptom and we POC test them and it's negative, they're still recommending us to send them home.
Yeah. Mm-hmm. I saw in September a lot of pollen allergies or hayweed allergies that people had every year, but got worried about. I'm not seeing as much as that right now after we had our cold spot. The good news, I think, is we're not seeing much viral upper respiratory non-COVID illness this year. Are you seeing any of that in your staff?
We've had a few cases.
Yeah. But we certainly have had, I called the worried well, who with a little sniffle have asked to go to be tested, and once tested, we can't bring them in until the testing result is there. And then this past week, we had the burnouts. Have you seen the burnouts? Had some staff who went on vacation and came back, or were supposed to come back on Monday, but called out with true fever and actual COVID. Have you seen the folks who took some time off and did in fact have exposures that perhaps they might not have had had they been doing their usual work activities? So I think all of these are challenges that we're all going to be facing. We have a number of facilities from Maryland, although this group is Pennsylvania. In Maryland, and actually, am I correct? This group is Pennsylvania?
Yes.
Yeah. I'm going to stop for a minute and sorry, that's my hospital team sending me messages, and I'll just ignore that for a moment. I actually was born and raised in Berks County, Pennsylvania. Did my undergraduate at the University of Pennsylvania before I came to Johns Hopkins for medical school. And one summer in college, I actually worked as a nursing assistant at one of the facilities that's on this call today. I won't tell you which one, but that's really where I found my interest and passion in geriatrics. And so I want to say thank you for the folks that were there 30 some years ago, which is when I was a college student, and really had such an impact. The quality of the care in the facility, the staffing who were there, and had such an impact on me that, and hard work. I've since, and actually this morning on my hospital rounds with my residents, we were caring for a nursing home patient from Genesis who had infection, not COVID, but infection. And as we were doing her exam, she had had fecal incontinence, and I taught my residents how to manage that. And we did a full skin exam and helped the patient. And I have to say, when the nursing assistant came in to help us finish up, I think she was like, wow, thank you, team, for working together. And so I hope we do all find that this is a give and take experience, and not just we at Johns Hopkins and Project ECHO are going to show you how to do everything right, because in fact we don't. And it is a team effort. Here in Maryland yesterday, the governor made a decree, and that decree was that every nursing facility must have in writing a partnership with a hospital, and a hospital where they would be sharing patients. And that partnership needs to include staffing and PPE and testing. That's a huge responsibility, but these partnerships of skilled nursing facility staff and hospital staff are what we believe will sustain us during this next long-term approach to COVID. What's happening in Pennsylvania with partnerships of hospitals and skilled nursing facilities? Anything you can educate me on?
Hi, I know it in Philadelphia, the Philadelphia City Health Department is actually pretty progressive in their thinking with protecting nursing home residents, and has been working directly with my facility in basically leasing 120 positive COVID beds on my entire second floor as a means for other Philadelphia or area nursing homes to be able to appropriately cohort them in a safe environment to be quarantined, to protect the integrity of any other nursing homes, or to provide assistance with offloading patients at hospitals if they are, at capacity.
That's terrific. How about PPE? Are they helping you with PPE?
They have in the past, because we're a part of Genesis. We're a large organization, so they have procured a lot of inventory just in case any facility is in need. But over the past 6 months, we have received shipments from assistance from them.
Great. How about staffing?
Well, as of right now, we're okay, knock on wood. I think one of our biggest challenges right now is bed management. And because of using the entire second floor for positive patients, we are still carrying long-term care residents on our first floor, and having an admission observation unit, and people going out for appointments if they have to, people going out to the hospital and needing to go to the observation unit, significant LOAs that we have to try to adhere to, trying to find a bed by themselves or on the observation unit. It's kind of like a big juggling act.
Mm-hmm. Yeah. All those things I think are so important. Anyone else having partnerships with their local hospitals? Anyone particularly challenged by this issue of hospital-SNF relationships? I think when in times of stress, as I was leaving last night, two of my new admissions yesterday afternoon had no beds in our hospital. One was actually sitting in a chair in the emergency room, just hoping that the bed would be ready in the next hour or two with the IV pole sitting next to them. And I know when we get to that level of stress, usually that happens 1 or 2 nights a year, and it's usually during the peak of flu season, so usually February, not November. But I know that there's pressures to discharge and sometimes earlier from the hospital than we might otherwise do to post-acute beds and for long-term care residents back to their long-term care bed. Are you seeing any of that right now in your referrals? All right. I know today there's a meeting in some of medical directors in Pennsylvania, and one of my colleagues in our national organization for medical directors is going to be speaking about hospital and skilled nursing facility partnerships. So I'm very happy that he's doing that, and I shared with him some of our protocols at Hopkins. Yesterday, I spoke with the New York Medical Directors Association and shared our GO teams, our hospital GO teams that did assist with testing when needed for the skilled nursing facilities and triage. We brought some palliative care providers with us too, and they reached out to families and particularly with goals of care discussions. Do you have any strategies yourselves on managing when there are active COVID cases and how you manage those in the facility? I think that is a topic we'll get to a bit later on in the curriculum, but I was just curious to see if that was a particularly important topic. I'm going to share my screen again and do a little bit more on the 16 weeks and what we're going to be doing together. So let me get there. So give me just a moment. And I'm going to get to the place in the curriculum. And here's our 16-week, let me get to the PowerPoint presentation and introduction. Let me start with the, let's see, where is it? Let me get the, so the 16-week curriculum, let me get to a, here are the topics we're going to be going over each week. So today's topic in detail is the preventing and limiting the spread, and kind of a general overview that I think, in my opinion, was a bit, we all are already doing this and knowing this. Then we'll dive into the individual topics more significantly each week, with the first major topic being practical approaches to personal protective equipment. And then a whole session on the cohorting practices. I'll share some of our early work at Johns Hopkins with our local skilled nursing facilities and show you some actual data on how cohorting made a difference, and particularly addressing some of our wandering dementia patients and how we managed cohorting for them. Then we'll be talking about the environment in general and making it safer. And then cleaning and disinfecting procedures in much more detail. The testing, it'll be interesting. We've certainly gone through various iterations of protocols for testing. So I'll be curious to see if the curriculum I've viewed now will be the same curriculum when we get to this topic. Because again, as testing strategies evolve, as testing types of testing become available and then not available, as we understand more about false positivity rates and false negative rates for different technologies. And as we get federal guidance and mandates, as well as state mandates, I think the testing topic is a real what is it today type of thing, but basically changing our approaches as we have new knowledge. And I think that's an important theme in all of COVID, is being open to new knowledge and changing protocols and practices, and then communicating those practices to our staff, to our residents who can understand, and to their surrogate decision makers and healthcare buddies so that the community understands what's happening in the nursing facility to prevent and mitigate outbreaks of COVID. And then a whole topic on the community transmission, and we certainly are experiencing that with our changes in community transmission, and therefore are more likely to see our associates being asymptomatic spreaders into our skilled nursing facilities. The topic of staff returning to work. Interprofessional team building and the management of COVID, and certainly that topic is evolving. We are talking about taking some of our hospital treatments and moving them into the skilled nursing facilities, and particularly those facilities with IV access. Some of our treatments that are IV only in the hospital setting may well be possible in a skilled nursing facility. I mentioned early on in our strike forces and go teams responding to outbreaks, the importance of goals of care discussions and in fact advanced care planning so that wishes of patients and their surrogate decision makers are well known before there's the need to make decisions on transfers. And then the transitions in care of the admissions and discharges and transfers, very timely as we are all having throughput challenges. A big topic here in Maryland was the visitation policies, and we know that health departments, state departments of health are making their own decisions based on community spread on visitation and what is safe visitation. But we'll talk about some of that, and certainly we saw in the fall the outdoor visitations, and now as we are getting into the more winter months, how do we prepare for indoor visitations that recognize the importance of quality of health, quality of life, and activities and visitations at a time when right now we're seeing an increase in the community. Very important to have the certified nursing assistants understand prevention strategies, symptom recognition, and managing active COVID, and supporting our residents and families during this time. And talking about staff as well as residents' social isolation. I mentioned earlier the burnout, and I have one member of my staff in our post-acute facility, as I mentioned, was on vacation last week, but now on leave because of active COVID, and knowing that that individual did have opportunities for social engagement that was just a matter of burnout, and the person felt awful when letting us all know that they're going to be out now because they knew that their exposure was something that could have been prevented, but just felt the need to get out and do a few things they hadn't done in 6 months. Again, that emotional well-being for all of us is so important. And leadership and communication, and the folks on this call are indeed leaders in Genesis and your individual facilities, and how do you set the tone and lead by example during this time, when in fact you're very worried about your own families, whether it be older family members that you're worried that you'll expose because you're in a facility every workday, or even young children and managing all the stresses. My children themselves are now doctors and actually working in various places for COVID, so I don't have the stresses personally on trying to educate children, but I can't imagine how challenging that is for all of you and who are doing so, and your staff as well. So hats off to everybody who's working so hard. There are resources in this program that the AHRQ and the leadership of Project ECHO have, and we'll be populating those in a site for everyone to access. There is an AHRQ site for Project Echo, and we'll be getting that information for how you log in to all of you. And again, I'm sorry, because of the short time that we were getting up and running, some of this that should have been done before this first session couldn't be done in time. But there is a website for you to go to at AHRQ. It's community.ihr.org. /echo, ECHO, but we'll get that to everybody. And then you actually establish your own, with your own email and password, access to the site. And you'll have access to our Johns Hopkins hub, where I'll be placing a lot of these resources for you to access. And I think it's very comforting to know when you have these types of materials that you're not alone. And importantly, with your cohort being all Genesis facilities, we'll be very sensitive to your corporate policies as well as your state mandates from your departments of health. And I think that's what was one of the important in the leadership of Genesis, keeping your corporate facilities together and regionally together as best they could, so that you can be sure that you're consistent. And certainly if you see something in one of these videos or PowerPoints that is inconsistent, point those out so that we are aware. And you've seen as I'm sharing my screen that I've been going to this website to pick up the required educational material that we review together at each of these sessions. But you can view it individually, or for those who miss a session, they can see them as well. Okay, and then there's actual literature as well in the library. So there are communities, and you'll find our Johns Hopkins community listed. And then under library, you'll find literature updates as well. If you have a particular interest in a topic related to the coronavirus. I think the pregnancy topic here, that's an example, may not be so relevant to what we do professionally, but certainly may be important to staff who are very concerned about their own personal health. And just a big thank you for taking the time and effort to be with all of us and sharing your experiences. And very important to say, every experience is so important. And during the time we're together, the more you participate, the more you get out of it, and the more we all get out of it. So please don't hesitate to be part of the discussion, and don't hesitate to challenge anything you see, because indeed our practices for COVID are so fluid, and we're willing to change our practices as new knowledge develops. And even our testing strategies are going to evolve as we have new types of technologies and hopefully more rapid and more sensitive and specific testing. So, so I'm going to stop sharing that right now. And let me just pause for any questions or comments before I move to the next, next topic. And let me just look at the chat to see if there's anything new there for me to address. I don't see anything there. I'm going to go back then to share the screen. And there is, let me get out of this particular presentation and get back to the main Project Echo. And there is an overview of the whole program now that we need to be viewing. Each one of these sessions, again, will have a key topic. And again, today's was this general overview topic of stopping the spread, and then an orientation to the project. And then there's a quality presentation from an expert from the Institute for Healthcare Improvement, the IHI. Today, we're going to hear from Alice Bonner on quality improvement. Before I do so, there's one more video that's required for this session, and I need to find that, and it's again an orientation to the project, and I need to find that, and I think it's in the, I thought it was there in my first session, but I'm not seeing it here, so I might have to send that as a link later on. for now, let's go to the presentation from Alice Bonner. And some of you may know Alice. She is a nurse practitioner, a doctor of nurse practitioner. She is now on staff with the IHI. Before that, she was very involved in Massachusetts in her own state health department. And even before that, she was here in Baltimore at the Center for Medicare and Medicaid Services. She actually was a leader in the nursing home branch and quality branch of nursing homes for CMS. Alice is on the board of the Mid-Atlantic Medical Directors Association, has been very active there in nurse practitioner involvement and care in nursing facilities. So she's very expert in quality improvement. So I'm going to go ahead and open that presentation.
Well, good morning, good afternoon, or good evening. This is Alice Bonner from the Institute for Healthcare Improvement, and I'm going to present just a very brief, maybe about 5-minute overview of Quality Assurance Performance Improvement, or QAPI, for nursing homes. You're going to hear a lot more about this topic in later sessions, but today we're just doing a very brief overview to get you thinking about QAPI. Now, the regulatory development really started back with the Affordable Care Act, and there's been some subsequent survey and certification letters after that, and it requires CMS to establish standards and provide technical assistance to nursing homes on the development of best practices related to QAPI. And surveyors may ask for QAPI plans at any point during a survey or upon request. Some of you may use this guide. It's called QAPI at a Glance. It's a short guide, maybe about 20 pages, and it was developed at the same time as the regulations were being written. It's still up to date, and it is a useful tool to help any nursing home as they're developing and putting together their QAPI plan. So it's just a good guide, a good framework, and it may be useful to you. Now, there are a number of basic features to QAPI that are outlined in this slide. This really sums it up in a nutshell. QAPI uses a systems approach. It works to improve quality of healthcare and the residents' environment, as well as the environment for workers and care partners. QAPI is really data-driven. That's one of the key elements, and it doesn't wait until an adverse event happens. It's proactive. It involves staff at all levels, and it identifies gaps in the center systems or processes and continuously monitors the effectiveness of any interventions. These are the 5 elements of QAPI just listed on this slide. And so as you're going through the development of your QAPI plan, or if you're revising your QAPI plan, you want to make sure all 5 of these elements are in the plan somewhere and are addressed. So we're not going to go into great detail today, but just very briefly, each of the elements. So element number 1, design and scope. It's got to demonstrate that the QAPI plan is ongoing, it's comprehensive, involves all departments, and that it really focuses on person-centeredness and autonomy and choice. The second element, leadership and governance. This is really critical. The leaders of the organization, whether it's the board or people in leadership positions in administration and clinical roles in leadership, must all be involved in QAPI. As we said, this is a data-driven process, so getting feedback and having data systems that allow you to collect the data and to be able to analyze it, this is really critical, and to be able to look at adverse events in order to develop action plans and to do a root cause analysis for each of those adverse events. Element 4, which is about performance improvement projects, sometimes called PIPs. This is a way to identify where there are gaps and opportunities, how to design and prioritize PIPs, and how to look at the data as a result. And then finally, systematic analysis and systemic action just gets back to the notion that this is a systems approach, and after doing initial PIPs, go back and look at where you can integrate all of these approaches together and align all of them in a systems approach. And this slide just sums up, these 12 action steps for how to develop a QAPI plan. Very, very high level, but again, you'll see this in QAPI at a glance. It's just a way to frame the work to get started. And in addition to QAPI at a glance, we provided these other references and resources which are on the CMS website. They're very helpful and gives a lot of examples of how to go forward. So that's all we have for today, less than 5 minutes, but if you have questions, this is my email. Please feel free to contact me. I'd be grateful to hear your thoughts, your ideas and suggestions, and answer any questions that you might have. So thanks for tuning in. Take care.
So quality improvement, quality assurance and performance improvement have been very big topics in our local state annual surveys for nursing homes here in Maryland. Is that true in Pennsylvania as well? When you've had your annual surveys, have you been asked to present your QAPI plan for the surveyors to review?
Yes.
And have anyone had experiences where that part of the survey process was particularly challenging, and what issues in particular were difficult? Or has that been an easy part of the survey process compared to patient or resident interviews and record reviews?
For me, I feel like it's been more of the less challenging. As long as you can show that if you do have an adverse event happen or an incident that you are, doing a QAPI plan specific to that, is what they're looking for specifically as it relates to, my field office that oversees me.
Mhm. We've had experiences where if there was a particular record review that was finding a deficiency, if in fact that issue had been identified by the facility and part of a quality improvement plan, that in fact we would not be cited. We've had that experience in some of our facilities. And that was a place where facility recognizing opportunities and having an action plan and having data have made a difference. Are you seeing that with your survey process in Pennsylvania?
Yes.
Mhm.
Yep.
Good.
I think we do QAPI every day,
Mhm.
but we just don't take credit for it.
Yep.
So it's learning to take credit for what we already do, what we've already built into our mind of how we react to certain situations. We just need to learn to take credit for it.
Has anyone put into their quality improvement plan COVID issues?
Yes.
Yeah, how in particular?
I think, hi, it's Erin. I'm the Director of Population Health for Genesis. One of them, I think somebody could speak to our QAPI workbook for COVID-19. We have a specific developed a QAPI workbook if somebody wants to speak to that.
So Erin, you have a corporate approach to this specific to COVID?
Yes.
Time of year.
Erin, it's Leah. I can speak to the copy workbook.
Thank you, Leah.
Yeah, no problem. So essentially, we complete walking around tools every shift, whether it's department heads, other nurses that complete them, to review the infection control practices as they relate to COVID-19 and facilities. It then is yes or no questions are answered, and it calculates a percentage score of like how well we're following an infection control. And then those are imported into a QAPI workbook so we can see how we're tracking and trending across all shifts, whether it's weekdays, weekends, and what our most frequent concerns are.
Very good, very good. And then Erin, on a corporate level, do you review these?
Yes, Michelle, we review them on a scheduled basis with the regional team with the centers. The centers present their QAPI workbooks, and then we problem solve for the areas that we think and do some gap analysis work and put some interventions in place. But usually the centers are just presenting to us what they have already did. We're just confirming that it's being done and that everything makes sense. But the centers do a really good job at it. So.
Terrific. Terrific. As you're looking at your current plans, is there an area in particular where anyone feels most vulnerable and wondering about how to go about a particular topic?
Hi, here at Harson, I think the biggest issue is just staff fatigue and just staff, is the glasses, wearing eye protection is a big one, it's just staff is over wearing it just like everybody else. And that's kind of like the biggest issue that keeps coming up.
Yeah, it's that marathon versus sprint approach, and you're right about the discomfort of PPE. Like I said, I now have the most lightweight, easy to use face shield that actually worked well in the rain for me coming over from the hospital, so it kept me dry. But yeah, twice on my morning rounds, I had to remind the medical students to put their face shields on. And said to them, make sure we all look at each other as we walk in the room and be sure we're all doing it. Fatigue and just more to do make it difficult for all of us. So absolutely, absolutely. Let's, for the last few minutes, and I'm not going to make this an hour and a half today, we're really going to keep it to an hour. But there's one topic that I did want to at least have a discussion on, and that's, and we'll talk about this more in depth, but a big issue for us right now in our closest facilities has been the visitation and the visitations around the holidays. Perhaps if there's a corporate policy for that, I don't know if Erin, you're the person to tell us about corporate policy or someone else. Where's Genesis falling on residents leaving the facility for either a few hours or a few days during the holidays?
Yep, we did develop a corporate approach and talking points. So we really are trying to discourage that, as sad as that may be, because of the unknowns into our community spread, and positivity rates are really going up as everybody else is seeing. So we did develop and gave the centers some guidance on how to go around that, extending holidays for over a week or 2 week period to increase the ability for visitation inside in common areas of the centers, and to redesign how we're going to do the holidays. But as far as the external LOAs during the holidays, we are trying to steer families away from that due to the increased risk.
Mm-hmm. Yeah, I certainly do support that, and that is what our approach has been here. I've seen some very thoughtful letters to families talking about this, and I have to say I'm beginning to see our news media beginning to make that a standard approach and supporting that. And where I saw, perhaps it was maybe July, August, our local news medias were featuring the stories of residents feeling isolated and family members being frustrated as we began to then open up to outdoor visitations. I'm now seeing I would say a groundswell of public opinion of making us all feel that these holidays will be different and finding new ways of celebrating that aren't groups, including our nursing home residents for visits outside the facility. Any approaches to actually how family members may participate in the facility? So are indoor visitations now part of corporate policy?
This is Michael Melnick at Edge Health. I'm Center Executive Director. And we have a special family Zoom conference call this afternoon at 4 p.m. And it's specifically titled the Extended Holiday Season Calendar, and what we're doing to extend the seasons, as it was Aaron had mentioned. But Thanksgiving is going to be a week-long celebration. Hanukkah, a week-long celebration. Christmas, Kwanzaa, New Year's Eve, to give the family members every opportunity they can to come in and visit with their loved ones. We have a indoor Four Seasons room that has an outdoor entrance after the screening, come in and visit. But we lead with all the special new events over extended period of time, and then we have our medical director be on this call to talk about why it's important that we discourage any leave of absences from the facility. So once we're selling in all the additional holiday measures that we're having internally for the residents and patients at the center, extending the visitation hours and dates, and then ultimately at the end, if there are any discussions in terms of leave of absences, after we talked about all the positive events, we addressed it at that time. We had a Zoom family meeting last week. We did touch upon this, but we have the meeting today at 4 o'clock, specifically for the holiday planning season. And it's worked out well to this point.
Terrific. Yep. Do most of your facilities have the ability to do these indoor visitations with the type of environment that allows for it?
I know we do at Edge Hill, and I've been at 7 different Genesis centers during the pandemic, and many of them have an area that's near an entrance that's away from the care rooms of the patient care areas, and that's been the Genesis guidance to have as much intervention. Genesis has gone out and sourced partitions. So any area that we have visitation is clearly marked for social distancing and screening of family members coming in, proper wearing of PPE. And so what I've seen at the 7 Genesis centers I've been at, yes, it's been very well presented, and there's been guidance given every step of the way by Genesis in terms of visitation, multi-page guidance, and how to properly and safely have family members come in and enjoy some time with their loved ones.
Terrific. Good. What are you doing with things like bringing in presents, clothing, food? Food in particular, I know has been a topic that people have been concerned about. I've served on a safety council for long-term care organization, and our safety council has talked a lot about this. And what we've said is that food from home and gifts are really a very low risk spread and a very much high importance for quality of life. And so our guidance, and my team that's guiding is an infectious disease physician, Morgan Katz. Maybe some of you have heard and read some of her literature on asymptomatic testing in nursing facilities. And her research is in infections in nursing homes. And she's come out and said, bringing in cookies from home is not a risk, and therefore you can allow it and encourage it. And it just helps with the quality of life. And the same with personal items. Do you have a corporate policy on that?
Yeah, it's Erin again. Yes, in the beginning of the pandemic, we were a little bit more stringent. In your March and April months, we were holding packages for like 24 to 48 hours. But again, as you mentioned, we realized that was a very low risk activity and it increases quality of life. So we do allow it. That's pretty much how we've been operating.
Good.
Yep.
Good. And that can go a long way. That and the Zoom calls, and I have to say, in my long-term care unit here, I have pretty medically complex since I run an LTAC type of facility. But they're very medically sick, but long-term care here. I've been really impressed with how families and many of our patients are getting more comfortable with Zoom visits. And sharing. I did rounds 2 days ago and walked in on a tea party, and my patient was having her cookies and tea, and her family were, and they were all doing it at the same time. And it was like Doc, you're going to have to come back because you're not going to interrupt our tea party. And the answer was, you're right. That's much more important than my visit and listening to your lungs today. So I think that's really, we're finding ways. But that personal touch is certainly something we all value, and having the ability to do indoor visitation safely is something that it sounds like your corporation really is trying to do well. Good. How about pets? Do you have your own facility pets in particular, or family pets? Where are you with family pets visiting? No pets. Christine says no pets. Is that a corporate policy? And I will tell you that I'll challenge you all to say that our safety council has said that pets are okay. So I know there's at least one report in the medical literature of animal spread. At this point, we are we're certainly thinking about that, and the high quality of having family pets visiting for us is something to consider. Okay. So I'm going to wrap up shortly. Before I do so, is there a burning area of, oh my God, we are here talking about COVID, and I just want to throw this out there? So anyone either in the chat or want to get on and say, help.
Hi. I think for everyone right now, we're kind of the pains that we're feeling are, testing our staff and residents consistently in the POC device, and it's very time consuming and uses up a lot of our staff's time, and it's a lot on the building. It's definitely a lot, and it's not only do we have COVID going on, but we have the operations of our building as well. Like, we just don't stop doing what we normally do because of COVID. So I think we're really trying to put some things in place to be able to support COVID testing and so forth.
I certainly agree with you. And I will tell you, at a national level, the type of testing being offered in nursing facilities, the costs, all of that is very high visibility, and trying to get some of this resolved. There are some very rapid tests and less invasive tests, and distributing them, being sure that there aren't significant false positives or false negatives of sufficient. So I do think we'll be seeing, and I wasn't joking about the fact that what's in the curriculum today will probably change by the time we get into more detail. But I can tell you there's a big effort to have the most rapid tests so that you can have the results in real time and not waiting when staff are off because they don't have the results, and that they are, because they're less invasive and not nasopharyngeal, they can be done more frequently, and then looking at the costs and who's paying for them. So I don't have all the answers for that today, but I can tell you it's rapidly evolving, and I am proud that some of our leadership in post-acute care and the American Medical Directors Association are leading the way in all of these topics. I think we'll come a long way from having these devices dropped off in these nursing facilities, some of which without reagents and without appropriate training in how to use them, and then resources for when there's a concern for false results. But we're not quite there yet, but I share your concern. We here in our own facilities are still primarily using nasopharyngeal PCR, but the reason we can do so is because we have our own laboratory that gives us a turnaround time that's within a day. And while that can be achieved, it is a high cost and not sustainable for the amount of time we feel we'll need it. But I am aware that some of the point of care testing that will be rolling out to nursing facilities will be easier to use and more cost effective. So hang in there a bit longer. Okay.
Yeah, we do have the POC devices. It's just mass testing
Mm-hmm.
is very difficult. My facilities were rather large, so we test about 200 staff members a week and over 100 residents, 120 residents.
It's a lot of quality data to be taken care of.
Yeah, and a lot of reporting to, not only the Department of Health, to our city health department, to our corporate office. It's
Right.
a lot.
And the last thing you needed today was a 90-minute session like this, right? So I have to tell you, I feel some of that frustration because there's a lot of boots on the ground time that we're all taking. So hats off to you for that. And I hope everybody's been eating lunch while you've been participating and multitasking a bit. Any other last comments? If not, I'm just going to go through the chat here real quickly to make sure I've gotten everything else out of there. Next week's topic is going to be PPE. And we'll have a presentation on practical approaches. But also, if you have something in your facility that you've found has made a big difference, and Martine, I'm looking at your picture and it looks like you have the same face shield that I have, nice and lightweight and easy to use. Good for you. You're zooming in, so I hope everybody can see you because I think that looks pretty comfortable. But if you found, I will hopefully bring one of the worst PPE I've ever seen. I call it my shower curtain. Has anybody been strapped with the isolation gowns that are made out of essentially shower curtain material? We had those for a couple of weeks. And I got to tell you that I started making my visits less and less because I was feeling like I was going to pass out pretty soon. And we went to the corporate leadership and said, no, we can't. This is not sustainable for our folks in the front lines trying to wear these things. Somebody says yes, and we still have some. Well, let's see what Eric can do about that, Aaron, because I know that it just isn't sustainable. And so we'll talk about that more in detail next week. And with that, I'm going to say thank you very much for such short notice, getting on, figuring out how to do this. We'll figure it out together. And if there are areas that you want more information on, please reach out to me. And again, a big thank you, and have a great day. And I'll see you all next Thursday at noon. And then we will break for the following week for Thanksgiving. And then when we regroup, it will be at 11 o'clock on Thursday mornings. Okay. And with that, I'll say good afternoon. Okay.
Thank you so much.
Bye-bye now.
Good afternoon. Thank you.
Thank you.
Yeah.